Hello, Assalamu alaikum. Welcome to another episode of Care Across Cultures. I'm your host, Mirban Hussain. You are listening to us on Link FM 96.7, linking communities. Our studio hotline, as always, is 0114 261 8181. We'd love to hear from you. Yeah. Any questions? Any observations? Anything you'd like to say? Or you can text us on WhatsApp 07939 849 339. Please remember, as always, all the views and opinions expressed on this programme belong to me and my guests and are not necessarily those of Link FM or of the organisations that we represent. And the other thing I really want to say is that, yes, all of my guests are practicing professionals, medical and nursing, and various other affiliations. However, this programme is an awareness raising programme. We talk about challenges, issues within the community, and the advice, or it's not advice that we give, it's information. If you do require medical help and support, the first place to go to is your GP or any other medical professional or nursing professional. So, we're discussing end-of-life care, hospices, palliative medicine, and these are topics that families often avoid, but here's the thing, you shouldn't. Because when we don't talk about these realities, loved ones may suffer unnecessarily and miss chances for comfort and dignity. Today we'll be tackling major fears and misconceptions, like hospice means giving up hope. I'll let that sink in a little bit. And concerns about pain medication. What happens? What does it do? We'll be covering both medical facts and cultural understandings to better support family members. And hopefully we'll also be breaking down some cultural barriers and giving you the confidence for these important family conversations. So joining me today is my wonderful guest, Dr. Arfeen, Fatima. Hello Arfeen, how are you today?
I'm fine, thank you.
Thank you so much for joining me today.
Thanks for the opportunity.
Okay, so before we start with the elephant in the room, okay, tell me a little bit about yourself, who you are, where you work.
So I'm a GP trainee. I'm ST1, like we say, it's a 3-year program. So I'll be ST2 soon, in a couple of months' time. And currently I'm working at the Rotherham Hospice, which is the palliative care medicine.
So just to make people aware, GP ST1 means GP, general practice, speciality training.
Yes, it is.
So where you spend, is it about 6 months or so in various disciplines?
Yes. It's depend on the deanery. So in the Yorkshire and Humber, we spend 6 months in different specialty and the GP practice as well. And then we move on in the final year as a GP registrar in the GP practice. So we have got the input and the specialty inputs from different areas.
So that, I know we were having a conversation earlier, yes, that your initial thoughts, plans were that you're going to become a GP.
Yes.
However, these may change depending on, because you found an affection, I would say, for palliative care, and you find that really, really...
It is. I think it's more, again, the holistic care that the GP provides as well, and the palliative is more holistic care as well. So I think I can see the similarities. More communication, more to know people as a family and how to support them, both physically, emotionally, and psychologically. So I think, yeah, there is a connection between them, and I would love to be working as a special interest with palliative, maybe. Let's see what the years come.
But we also had a conversation earlier, didn't we, about mental health and
Oh,
a
yes,
passion.
we did.
We both have a passion for mental health,
Yes.
and hopefully we can have, away from the program, we'll have a conversation about mental health and how that sort of impacts on palliative care, you know, trauma, lifelong illnesses, those kinds of things.
Yes.
Okay. I'm just to remind people that I'm planning a whole series of programs on mental health and how that impacts on people with cancer, life-limiting illnesses, and this should be coming up in October and November. So thank you for listening. If you've just joined us, you are listening to Care Across Cultures with me, Mehban Hussain, your host, and I'm having a conversation with Dr. Arfeen Fatima. So, Dr. Fatima, now, I always have this issue because I think doctor should be called doctor, but I think the new thing is that, you know, we all prefer first names.
First name, yes.
Okay.
Yeah.
So, Arfeen, South Asian families, and I know that's a big generalization,
Yes.
okay, think that hospice care means giving up. What would you say to them?
Unfortunately, that is the perception we have, and this is across cultures, to be honest, not only South Asian, this is across cultures. But I think this is, of course, not the truth. So let's understand what the palliative medicine first and where comes the hospice is there. So the palliative medicine, it again deals with the holistic care. It's not about absolutely the very end, but it provides the symptom control. Like at times, for example, a patient is there, the pain management is difficult at home or with the GP, so he's being referred to palliative. We support his pain symptoms, like when the pain is controlled, he can have more treatment, he can eat well, sleep well, mobilize well. So that's the palliative care is. And of course, the hospice is the area where we provide palliative care as an inpatient. We look at, of course, the physical side of the patient. We look at the families, support them emotionally, psychologically, and of course address their spiritual needs as well, and make plan for the future, like what the patient wishes, values, and concerns are.
So I think, you know, I'm really interested in making plans because I know that I've spoke about advanced care planning previously.
Yeah.
But advanced care planning is not necessarily about end of life, is it?
No, it's more about how you want to see yourself in, you know, like down the few years. At times when patients are diagnosed with cancer, for instance, they go to their oncologist, they have their prognosis, then it's not a mandatory thing. Of course, it's a voluntary thing. If you want to have a discussion, so advanced care planning basically is a process of discussion where we discuss and then document the wishes, the preferences, the values of the patient. It entails, of course, an open discussion with the family and the patient. We take on board if the patient want to discuss their resuscitation, about future hospital admission, about their wishes regarding the end of life, meaning how they want to spend the last days. At times people want to spend that at home, and other instances people want to come to hospice and then spend their time home, with the end of life, and of course supporting the family, because there's a lot of burden on the caregivers as well. So we support them with, you know, their counseling services for them. Of course, they can plan things in advance. At times, the legalities like the lasting power of attorney for health and welfare. So the advanced care plan entails all of those.
Right, thank you so much for that. The next question I've got for you, and I'm so glad that I've got somebody else who speaks Urdu as well today. So, अगर आप के पास कोई पेशेंट है और उसका बेटा या बेटी कहते हैं मुझे ये मत बताओ, मेरी माँ का मत बताओ कि वो मर रही है, क्या जवाब देंगे आप?
इसमें दो तीन चीजें हैं कि एक तो पहले आप एक्सप्लोर करें, अंडरस्टैंड करें कि बेटा ये क्यों कह रहा है. सो एट टाइम्स ऐसा होता है कि बेटा इसलिए कह रहा है, शायद उनका प्रीवियस एक्सपीरियंस उनके किसी और फैमिली मेंबर के साथ या दोस्त के साथ ऐसा है, और मोस्ट ऑफ द टाइम वो सिर्फ आउट ऑफ लव, आउट ऑफ कंसर्न फॉर देयर मदर वो कह रहे होते हैं. वो नहीं चाहते कि उनकी वालदा को कोई परेशानी हो, कोई उनको कोई डिसअपॉइंटमेंट हो, अफसोस हो. फ्रॉम अ पेरेंट्स पर्सपेक्टिव अक्सर वालिदैन बहुत स्ट्रांग होते हैं, इतना जितना हम समझते हैं उससे बहुत ज्यादा होता है, और पेरेंट्स नहीं चाहते कि बच्चे परेशान हो. इन बोथ द केसेस हम एक दूसरे के लिए परेशान हो रहे होते हैं. बट लीगली लॉ इस कंट्री में ये है कि आपको पेशेंट की विल इज द मोस्ट इम्पोर्टेंट थिंग. तो हमको हमें पेशेंट को बताना है, और ऑफ कोर्स हम उन पे फोर्स नहीं करते इन्फॉर्मेशन. वी आस्क द पेशेंट हाउ मच, उनको कितना पता होना चाहिए, वो कितना जानना चाहते हैं, और हम एक दफा में सारी बात नहीं बताते, आहिस्ता आहिस्ता एज मच एज दे कैन टेक इन एन इंस्टेंस हम उनको उतना बताते हैं. और हम जो है उनके बेटे को पहले एक्सप्लोर करेंगे सारी चीजें कि भाई वो उनकी क्यों ये परेशानी है. फिर ऑफ कोर्स उनके साथ अगर पेशेंट चाहेगा तो दोनों को साथ बिठा के हम डिस्कस कर सकते हैं कि क्या चीजें हैं और क्या नहीं है. और जब तक पेशेंट को अपनी बीमारी के बारे में पता नहीं होगा, वो अपने ट्रीटमेंट ऑप्शंस को कैसे एक्सप्लोर करेंगे. लाइक अगर वो ऑन्कोलॉजिस्ट के पास जा रहे हैं, उनको अगर उनकी डायग्नोसिस पता है, उनको पता है कि प्रोग्नोसिस लाइक वी के मंथ्स है, ईयर्स है, फिर उनको ऑप्शन दी जाएंगी ये ट्रीटमेंट अवेलेबल है. अगर आप उससे बीमारी छुपा लेंगे तो आपका तो आगे का सफर फिर बिल्कुल नामुमकिन हो गया, मुश्किल हो जाएगा. तो इसलिए उसको बताना जरूरी, और बाय लॉ हम पेशेंट की विल इज द मेन थिंग.
हाँ, इस मुल्क में तो है ना वो जो है जिसे कहते हैं ट्रूथ टेलिंग, सच बोलना.
बिल्कुल बिल्कुल. इसलिए कि हम पेशेंट की मर्जी के खिलाफ अगर कोई काम करेंगे तो ये जो है अनलॉफुल है. मतलब ये लॉ हमारे साथ नहीं होगा, ये एक तरह से असॉल्ट होगा कि हमने पेशेंट की मर्जी के खिलाफ काम किया. लेकिन मर्जी उस वक्त उसी वक्त पता होगी जब उसको पेशेंट को रियलिटी पता होगी.
बिल्कुल बिल्कुल. Thank you so much for that. So I want to go on to the next thing, is that, and this is about family hierarchy. When the eldest son makes all the decisions, I am the eldest son, but the patient wants something different.
Yes.
How do you navigate this?
So again, the start of the navigation is just to explore with the patient why they want to have their choice or not the patient choice. So at times what happens is that they are coming again maybe from a background knowledge that they want this option for their mother and that option for not for their mother. So exploring why they want it, and of course we can have an open discussions with the families, with the hierarchy, explore thoughts and come to a conclusion. We may agree to disagree at times, but at times we can be on a single page. Now setting the scene is maybe दो तरह के पेशेंट्स हो सकते हैं, like if the patient has capacity and if the patient has not got the capacity. So what I mean by the mental capacity is if the patient is able to understand, it can weigh, it can communicate, it can have the information, weigh it, communicate it to us, then that is said to be have the patient has the mental capacity, meaning they can take their decision on their own and they can communicate their decision to us. So if the patient has the mental capacity, the patient decides what they want to do and what they don't want to do. When the patient has not got the capacity, like they're delirious, they're confused, they're agitated, and we do see these patients like even with the sepsis, like patient, is confused. In that case, the medical team looking after the patient, they decide in the patient's best interest.
Yes.
And of course, the family can be taken on board, but of course they cannot dictate the decision. It's the best decision that in the patient's best interest that the medical team takes.
So that in that case, when a person doesn't have mental capacity, it's the medical team who take the decision with the patient's family members, but ultimately it's the medical team that make the final decision.
Yes, of course. Okay. Unless patient has something called the lasting power of attorney for health and welfare. Even in that case, we do take the consideration from the power of attorney, but that is not determinative.
Okay.
So it's the decision of the medical team, but we do take on board the considerations that the lasting power of attorney has.
And I just want you to expand a little bit more on this lasting power of attorney and this decision making, because मैं समझता हूँ कि आम लोग जो है ना ज़्यादातर ये नहीं समझते कि डिसीजन जो है ना कौन बनाएगा उस वक्त.
सही.
क्योंकि हर आदमी सोचता है मेरी माँ है, मेरा बाप है, मेरी बेटी है, ये है, समझा है ना, हमारा ज्यादा हक है. बिकॉज देयर इज अ कल्चरल
Bilkul, bilkul.
understanding, traditional understandings. And even within some families, there'll be that the whole family have agreed that, the eldest son or the youngest son or whoever is the one that's going to make these decisions. They've come to a democratic...
Yeah, it's a consensus among the family.
It's a consensus among... But even in that situation, it's ultimately the doctors who will make the best decision.
But of course, we take families on board. We discuss with them. We describe the rationale of our decision.
Yes.
And of course, that is coming from experience, the medical background and everything. But of course, if there are any wishes that the patient has made, or there are any concern that the family has, we can always sit down, discuss, and come to the conclusion. But of course, being a medic, we have to respect the rights of the patient and just make the best interest in their
But
case.
ultimately, आप ये कह रहे हैं कि जो decision बनाएंगे medical team, एक आदमी तो नहीं है ना वहाँ.
बिल्कुल नहीं.
There's lots and lots of different people.
बिल्कुल.
So जो decision बनेगा वो जो है ना patient की interest के लिए
बिल्कुल, बिल्कुल.
उनकी पेन को खत्म करने के लिए, उनकी लाइफ जो है ना अच्छी बनाने के लिए जितनी हम कर सकते हैं.
बिल्कुल, बिल्कुल.
Thank you so much for that. If you've just tuned in, you are listening to Care Across Cultures with me, Mirban Hussain, your host. I'm talking to Dr. Arfeen Fatima from Rotherham Hospice. I'm really pleased today because I don't have to translate as I usually have to, but today, we have Dr. Arfeen who can speak Urdu really well, and, we're having that sort of... when two bilingual people get together, you just mix up these languages automatically, don't we? Which
Absolutely.
is really, really great. Okay. So I was going to ask about a diagnosis conversation that when the family and the patient disagree about sharing information. Okay. But I understand from what you said earlier, it would always be the patient's wishes that take precedence.
Yes, absolutely,
Yeah?
absolutely.
Okay.
Yeah.
That's okay. So one of the things that somebody mentioned to me, quite a few people have mentioned, is that pain medication, morphine specifically. There is another issue around medication and where it comes from, in terms of how was it created, how was it made, is it halal? That's a different, separate conversation.
Yeah.
But the conversation I want to have today is that can you become addicted to pain medication if you're terminally ill?
So there are two things. One is, I think we often confuse addiction and dependence. So addiction is when you use something to get a high.
Okay.
And just accepting the negative, all the negative aspects of it as well. It will be harmful, but you are taking it for a high. Dependence is when you're taking a certain medication for a longer time, the body get dependent on it, and when it is taken off the system, you might have withdrawal symptoms. So with morphine, there's nothing like addiction. Because you're not using it to get a high.
No.
You're using it to get comforted, to get the pain relief. And even with the shortness of breath, morphine is very useful. So just to control the pain, you are taking it. And it's not like you are starting on a very high dose or something. Depending on the patient, every patient is so different, Mirban, that at times we feel like patients are very sensitive to morphine. So they're not suitable for a conventional morphine. We have other options for them. And we start on a very low dose, and work our way up, just monitoring the patient, just seeing the side effects, just helping them with how to manage the side effect. Like, with the morphine, a lot of patients have, constipation. So we take that on board, how to manage the side effects, how to optimize the pain control by monitoring the dose of the morphine as well. So there's no addiction to it. It's very, very rare, I would say. But again, we link morphine a lot to the end of life as well. After even a cesarean section, you get morphine. After any surgery to control the pain, you will get morphine. You'll take it for a couple of doses, a day or two, and you're fine. You don't have to wean off from it or anything. because it's only for a short-term use. When it comes to end of life, of course, this is the mainstay, because we want our dear ones to be comfortable. When they are comfortable, you can have more quality time with them. When the pain is controlled, as I said, they can mobilize, they can eat well, they can sleep well, and then the family can have more quality time with their dear ones.
And I think this is, you mentioned burden earlier, that the families, we can relieve some of the burden away if they go to hospices. But there are many families who don't think of it as a burden. They think of it as a blessing.
Absolutely.
In the sense that they are given an opportunity to care for their loved one, and they will get blessings and brownie points, as I always call them, in the afterlife.
Absolutely.
Okay.
Yeah.
So there's that aspect as well. So I think that's a challenge as well, isn't it? Because sometimes what may happen, I found, is that because we are giving one thing priority of, this is a blessing, and at the expense of our own health and well-being. And it's a difficult one to manage, I suppose. How would you talk to someone if they said that to you?
Yes. It's just, again, exploring more. So at times, yes, it's a blessing. We take it as a blessing. And it is indeed a blessing to look after your parents when they're elderly, when they're, of course, not very well, and you can see they're deteriorating day by day. But you can only give good care if you're well in yourself.
Yes.
So to keep yourself well, there are a lot of support in the community, and that's where I feel as a South Asian family, we shy away from asking for help. We feel that it's our weakness, that we are unable to cope, that we are asking for help. But like, for instance, there is, like, the carers can be there up to 4 times a day. So when you are, when you are referred to the palliative, like medicine, the community team, they come out, they help you with the medication. They can bring this package that you can have the carers 4 times a day. At times, towards the very end of life, they do offer the night sit-ins as well, because of course if the patient is quite agitated or restless throughout the night, the carer can't sleep as well, because they're on their toes. So at times, towards the very end, depending on the community, of course, we are dealing with, we have the night sit-ins as well, so they can come in and help with that. We have got the carer support, and towards the very end of life, when we are talking in short weeks and months, the care support is absolutely free. And outside of that, yes, the family needs to contribute towards the cost, but it's all free. So just, asking for those supports. We have got the counseling session for the families as well, the counseling for the patients as well. All these things, they're there to help the carer so they can deliver in a better way. We don't want them to get exhausted, and eventually they won't be able to.
They won't be able to, and they'll become ill as well.
Care,
And who's going to then look after them?
Absolutely, absolutely.
We're just going into a short commercial break, and we will be back in a few minutes. Assalamu alaikum, hello and welcome back to Care Across Cultures with me, your host Mehban Hussain. You're listening to us on Link FM 96.7. Our studio hotlines are open if you'd like to call us on 0114 261 8181, or you can send us a WhatsApp message on 079 398 49339. I'm in conversation with the wonderful Dr. Arfeen Fatima. We've had a wonderful conversation so far. Arfeen, I just want to sort of carry on a little bit more about morphine.
Okay.
And the question I have is that, what does uncontrolled pain actually do to a person's final days?
So just to give an example, like if we as a normal being with the in a healthy state, if we are having a toothache, for instance, if we keep having it, we don't take anything, we keep saying it's driving us mad, it's unbearable, we get agitated, we get restless. If a person is towards the end of life, of course they've got a background illness. Let's say, again, the cancer being most of the patient we deal with. So if they've got a bony metastasis, or if they've got a backache, for instance, if the pain is not well controlled, they can be really agitated, they can be restless, they can be fidgeting in the bed at times. They're just, and at times when they're so much in pain, and towards the end when they're a bit muddled up or confused as well, because if you've been tolerating pain for so long, you can be really confused. If you're confused, you are unable to express that you need a painkiller. So these are the signs that we see that the patient he needs some sort of a comfort, some sort of the pain management, and then we have got variety of options to deal with. Of course, we start as low dose, as I said. It can be oral, injectables, patches, and at times now it has been so wonderful that even before moving the pain, we can give an instant pain relief that works in seconds to minutes, and then we can move. So there's a lot of options we can give.
Thank you so much. I just want to, a final point on that is that कुछ लोग कहते हैं कि ये जो तकलीफ में देख रहा हूँ ना, ये तो हमारे गुनाह माफ हो रहे हैं, ठीक है ना? And as Muslims, we believe that. But I'm just thinking that, you know, how much pain, where do we sort of put an end to this, that actually it's okay, that yes, we are. I think we need to maybe an imam or a scholar who can guide us a little bit more on that. But what, as a doctor, what are your sort of views on that?
I think we have seen cases where the patient do feel that, but I always say in all religion, I am a Muslim, and in all religion, the compassion, the dignity, and just, you know, like controlling the severity of symptom is the key thing to make people comfortable, to make them comfortable, and the dignity is the main thing. Why let somebody suffer in pain and just see them suffering? Of course, you know, Allah knows how much of the guna is being cleared off, you know, in pain. We don't know, but towards the end, as a medic, our duty is to comfort them. As a family, I would not like to see my parent just suffering in pain in front of my eyes. I want them to be dignified, comforted, and just being looked after in a nice way. And that's where, as you rightly said, the religious scholars, they come into help. And at times we do ask them, the faith leaders, the community leaders, to come in and bridge the gap. And we have been very lucky that we have got some sane voices around. They come, they help us out, they comfort the patient, they comfort the family. Because if you believe in the faith, I think it's very important to have those leaders on board as well, who can come and just, you know, like help us communicate as well. At times they comfort the patients as well, and it's
a two-way
helpful
process as well, as both for the medics and the nurses as well, for the hospice staff, that, you know, they can get a better understanding of this.
Absolutely, absolutely.
And it's that, I suppose, that multidisciplinary team that you mentioned right at the beginning. It's holistic care, which is really your sort of you know, ball game, and that's what we provide at hospices across the country. Yes, I know we talk about Rotherham, and I know we talk about Rotherham Hospice, but what we're talking about and what we're discussing is available at hospices across the country. There will be a hospice wherever you are. There will be a hospice close to you. If you have any issues, if you need any help, support, information, guidance, please reach out. Ring them, turn up at reception, go and find out more. But as always with any kind of illness, your first port of call is always your GP. That's where you need to go first, and then, you know, look at, okay. So one of the things that, you know, we have found from data for decades now is that some members of society, some cohorts of people, wait too long before they start accessing care or support. I mean, in cancer, I've spoken about this many times, there are 4 stages of cancer, and if you can access support at stages 1 and 2, your survival rates are 100%, and in 3 and 4 it goes to 50%. This is for some of the main cancers, not all cancers.
Of course.
So why do South Asian families in particular wait too long?
I think it's again having the awareness and education what supports are available in the community. So if you know how much you can be supported, I think we will reach out earlier. And again, having the awareness for the symptom, again, the diagnosis of the cancer in itself, if you reach out to your GP first immediately, and just if there's anything, if there isn't anything abnormal, even then it's a reassurance, isn't it,
Yes.
that everything is fine. So reach out to your GP. So normally how the patient come to us, to the hospices, either referred by GP, either referred by the district nurses or by the hospital team as well. When they see that their needs are more complex, they need a hospice inpatient, and
Yes.
that's where they come up with us. But of course, don't wait too long. Ask help. There is help around, and there's more to it. Like the hospice provides, the support they provide is immense. If you ask them, I need help, especially in a time with the social care and how to make the will. I have recently seen like the wedding arranged in the hospice
Yes, we
as
did
well.
a wedding
Yes,
yesterday.
yes.
Yeah, yeah.
So of course,
Yeah.
if this is the wish of the patient towards
Yeah.
the end of their life, why not respect it? Why not
Yeah.
go through it? We have got the parties arranged for the children in the hospice.
We do.
So all sorts of these things, but of course we can only ask and know, and then we'll know what else is on the board that we can accept. So yes, I would ask them, everybody, if you're struggling, if you think there's something you need help or advice or just wanted to get it reviewed, please do reach out to your GP, reach out to any other support like the hospital, or just speak to your, if you have got cancer and you want to know more about end of life, ask with your oncology. They might refer
Yes.
you to the palliative medicine to explore.
And I'm glad you mentioned oncology just now, because just for those of us who are listening, if you've not come across oncology before, that's your cancer doctor.
Yes.
That's the doctor who treats you for cancer. Now, we've talked about palliative care quite a lot on this programme. Can you still have palliative care while you're getting cancer treatment?
Absolutely. Absolutely, you can. So now the new guidelines again are that if you are referred to palliative, again just busting the myth that palliative is end of life. It
Yes.
is not. So when you're referred to palliative care, we support the symptom, so you're fit enough to get more treatment.
Yes.
So there's no bearing on the treatment. If you're referred to palliative medicine, you can continue your own treatment. Yes, unless the team decide that you are the end of life and the patient decide that they don't want to continue anymore, that's a different story. But for the long-term illnesses, especially with the chemotherapy, immunotherapy, whatever patients are receiving, they can be under the palliative medicine for support management, for having a support, like emotional, psychological support, symptom support, and they can continue with the
So
background treatment.
for example, say that there's a patient who's recently been diagnosed with, some kind of cancer, and they're getting treatment at Western Park in Sheffield. Okay. And can they then access support from a hospice for palliative care, or how would it work?
So I'm not, I don't work at Western Park,
Yeah.
so I think they would be the best person to speak for that. But, what I have heard and understood is the oncology team, the cancer team, they refer to the palliative medicine team.
Right, okay.
And the palliative medicine is hospice, but more community as well.
Okay.
So the nurses go out and they see the patient at home.
Yeah.
We prescribe medication. They can be delivered at their home as well.
Right.
They support emotional support, psychological support can be provided. Again, discussion about the carers can be discussed with the community
Yes.
palliative team. So yes, if you are under a cancer team, you can ask them, or if they see like you need some more symptom control, they might refer to the palliative medicine. Now then the palliative medicine team decides whether you need a community support or a
Right.
hospice support.
Right.
And of course, with the hospice or the community, we have got a we are very connected with the other specialties as
Of
well.
course, yes.
Like at times we discuss the pain control. I forgot to mention that it's not only morphine. At times, if we see the need is complex, we can arrange the radiotherapy or speak to the oncologist regarding the radiotherapy for the pain management. At times, we discuss with the hospital and arrange a nerve block or something. If we think that the need is complex, we address them. We arrange investigation to address the needs as well. So it's all about holistic, as we said,
Yes.
that we take a lot of specialties on board and we work together.
That's great. Thank you so much. Wanted to look now is, so you work on the inpatient unit,
Yes,
yes?
I do.
Okay. So Mr. Khan has just been admitted on the IPU, the inpatient unit at Rotherham Hospice, and you go and see him.
Yes.
Tell me what happens next.
So when the patient comes to us, of course, what we say is clerking. So how we start is to get to know the patient. So know how much they understand about this referral to the hospital. What are their expectations? And it's interesting to know what people think it is and what actually we can provide. So just to understand their knowledge about it, their expectations, and what they understand out of this referral, that why they have been referred to hospice. And then, of course, we tell them what we plan to do, how we want to do things, what their wishes are. We take it on board and plan things and work it around. So, of course, it is the symptom control, it is the pain management. At times, we are being asked to speak to the family and make them understand or take them on board with what we plan to do. So we include the family. At times, if we ask the family if they need any counseling, any support, it's always difficult to hear the bad news or the worsening. If the prognosis is, it's a short month or weeks we're talking about, all that. So we've got all that.
So what I'm thinking is, Arfeen, that if Mr. Khan happens to speak Urdu and he gets you, maybe his English is not great.
Yeah.
But he's in a win-win situation because you can converse with him and communicate with him because you happen to be bilingual and you can speak that language. What if he speaks Pashto, which you don't speak?
Yeah.
What would you do then, and nobody else speaks Pashto, and he's got no family? What would you do then?
So it's not only about Mr. Khan. So while working in the obs and gynae, I've seen patients who speak Polish or Roman or any other language. So there is interpreter service available. So we can choose which language they want to speak, and we can communicate via interpreter. Because it's a professional setting. We need to keep it more professional. The sharing of information is the key thing. So we tend not to use any interpreter. We used to have our own interpreter service that can interpret for us, because of course there's the medical information being shared and discussed on board. And at times when the family members do offer to be the interpreter, we can use them in the dire situation, but ideally we use the service. Yes.
Right. Okay. No, that's great. I just want. Yes, and Mr. Khan just happened to pop into my head. It is, it could be anybody.
Yeah, of course.
If there's a language issue, interpreter services are available.
Yes.
Right, okay. So we talked about the caregiver burden earlier. How do you support the daughter-in-law? Because it's usually, I think, the daughter-in-law who's doing all the care.
So again,
but let me make it make it a bit more difficult.
Okay.
So we've got the daughter-in-law, and she's got children of her own. And she's also working part-time with kids. That is something that's happening quite a lot these days. So
again, it might not be only the daughter-in-law. When we discuss the patient prognosis, the challenges that comes with the diagnosis, we do have the family on board. So when in the discussion, the son might be there, there are other family members, the sisters or anybody else might be there. So we do tell them that it's very difficult, and again the services we offer, like the carers, the counseling services, the support that can be provided, we do offer them and ask them that if there's only one person looking after the children and the grown-up, we can only suggest that if you want to take it, we can facilitate it for you. So that's how we approach, that we offer them what can be offered and then take things from there. And again, as a family, as a community, I think at times it does happen that there's only one person looking after so many things, juggling around the life chores. But of course, it's only humanly impossible to give a quality care to everybody, because the children need time, you need time for yourself as well,
Yes.
and the person you're looking after needs some time as well. So it's always good to ask for help and just have the help around that you can see. And as a family, just think twice,
Yeah.
how much we are expecting from one person as well.
Yes.
It's not appropriate religiously, culturally, or like on any other grounds.
On any other ground.
grounds,
Okay.
yeah.
So, what I want to talk a little bit now is about, we've spoke really about inpatient care.
Mm.
So that's if you're in the hospice
Yes.
inpatient unit, okay, where you have 24/7 care.
Absolutely.
Doctors, nurses, everybody's available. Now, and we also talked about choice, didn't we?
Yes.
That some people would prefer to be looked after at home.
Yes.
And I know that we have an amazing hospice at home service,
Yes.
which provides the same kind of care and support,
Absolutely.
medical and nursing,
Mm.
that you can get as an inpatient unit, but without the 24/7 care.
Yes.
And for that, the hospice has a 24/7 helpline.
Yes.
Okay,
Mm.
and this is really vital, because I think we're talking about Rotherham Hospice, but hospices across the country will have very similar services.
Yes.
So it's 2 a.m.
Mm.
Okay,
Mm.
pain is getting worse.
Mm.
What should a family do? And they're at home.
Yes. So fortunately, I have done a good 6 weeks in the community side with the hospice at home
Okay,
team. So, which is helpful. So at 2 a.m., the important thing to know for the families, they're never alone. That's the key message. If you can take, they're never alone. There's always somebody is there to help. So let's take 3 scenarios. So the first one, that you are known to the palliative medicine.
Yes.
You have got the injectables at home. The patient is doubling up in pain. You don't know what to do. You call, as you rightly said, the 24 hours helpline. Call the hospice and say, oh, this is what's happening. They might send their nurse, or they ask you to call the district nurse. They can come and administer the medication. The medication, the prescription drug chart, they're all at home. They can come and administer it. The second is, there a new symptom that you're concerned about. You can call out of hours GPs, 111, to just ask for help. Or there's something more serious, like a clot, or you're bleeding, or it's a cord compression, like you feel like your limbs are getting numb, you can't feel anything down below. You need to go to A&E straight away.
Yes.
And that's how
And
you
that's
address
it.
at 2 a.m.
So there's more than one option.
Absolutely, absolutely.
The first thing is, don't panic. There is lots of help.
Absolutely.
out
You're
there.
never alone. You're
You-
never alone. Yes.
So that's great. Thank you so much. We're coming to 10 minutes to 12, and if you've just tuned in, you are listening to Link FM 96.7 Care Across Cultures with me, your host, Mirban Hussain. I've been having a wonderful conversation with Dr. Arfeen Fatima, who's a GP speciality trainee at Rotherham Hospice. We've had a wonderful conversation. I've been blessed today because Arfeen can speak Urdu as well, so we've had a wonderful conversation in 2 languages, and I hope that our listeners have found that useful. There are a couple of things that I really want to talk about now, and I will start with, first of all, there is that hospice care is free of charge
Yes.
across the country.
Mm.
Okay, and the way that we do that is that it's through fundraising, it's through donations, and I know that we were talking right at the beginning of our program, and you mentioned something about fundraising from South Asian communities, and I want you to talk a little bit about that. So, because you said that you haven't seen,
Yes.
okay,
Yes.
so what message would you like to give our listeners on that specific topic?
Okay. So, with as you rightly said, the hospice, they are around 20 to 30% funded by government, and
Well,
the rest is
Ours is
you know,
37%.
yes.
Yeah,
So,
but-
and the rest
yeah.
is from the funding from the people, the charity.
Yeah.
So, as a South Asian community, I have not witnessed, though it's only me, but I want to remind myself and everybody in the community that I think we owe this to the community and to the service providers, that we should work towards raising awareness, education, and charity to support the hospice or any other charity that you believe or you feel for.
Yeah.
Because at the end of the day, of course, these are the services that are helping people who need it. We are blessed with NHS in England, that the things are free for everybody, whether you're rich, you're poor, you're on the streets.
Yes.
Things are free for you. So I think we owe it that we need to give it back as well.
Yes.
If we can arrange some coffee mornings.
Yeah.
We can do the fun run. The hospice, I know the Rotherham Hospice, they arrange, some charity events.
Yes.
We can just gain, like some charity for them, or any other hospice or
Yeah.
any other charity you believe in. I think as a community, and we are a very charitable community, we do collect, we do participate in philanthropy and lots of things. So I think it's time we should consider giving it to our local services.
I just
as
want to
well.
temper that a little slightly, because I do know of many Pakistani families who donate to Rotherham Hospice.
Yes.
And they donate a lot of money, but one of the things that the most sort of Muslims tend to do is that if you're giving charity, they don't want to be recognised for it.
Yes.
Okay.
Yeah.
And that's fine.
That's absolutely
fine. That's
fine.
absolutely
Yeah.
fine. But however, there is this thing around. I like the coffee morning, and I don't know, maybe a paranta eating contest.
Yeah. Why not?
Yeah. So this is a shout out for everybody across the country who's listening. If you are from a South Asian community and you have a local hospice or any other charity,
Yeah.
get in touch with them, because if we don't support them and if you don't support them, it's very difficult to provide free care. Thank you so much for that. So the final question I have for you is that, have you got we've only got about a minute left now, a final message that you'd like to give to our audience?
Yes. I think as the community, we should be more open in our communication. If you've got any concern, please reach out to the right medical advice, your GP. We discuss within ourselves. We don't go out to seek help from the right people. Speak to your GP, explore options, be more honest and open in communication. Everybody is here to help. Nobody judges everybody. If you are having a doubt or anything, you won't be judged for that.
No.
Just be open, just ask questions. If you're referred to specialties, do attend the appointments, seek advice. If you want to do parallel things like the dua and whatever, this is part of our faith. Keep doing that. But stick to the medical side of it as well. Seek help, stick to the medical treatment, and we are all here to support. And you're never alone, even if you're in the middle of the night. There's support.
Thank you so much. You've been listening to Care Across Culture with me, your host, Mehban Hussain, on Link FM 96.7. That's the end of the programme today. We'll be back next week with another day in the life of a health professional. Allah Hafiz, until next week.